Hi, my name is Connie Koklanis and you're watching the video on the management of fully accommodative esotropias. Now, as you would expect, one of the main ways of treating a patient with a fully accommodative esotropia will be to correct the refractive error. It is important when you're correcting the hypermetropia that you fully correct the hypermetropia. And the reason it's important to fully correct it is because if you leave a patient undercorrected, you run the risk of the strabismus being manifest or remaining manifest with the glasses on. So you want to give them as much plus as you find on the retinoscope so that the patient has the potential of being straight with the glasses on. And it's important actually to annually review your retinoscopy of these patients because as these individuals or as these children get older, they become more cooperative during testing and your determination of the refractive error will become more accurate. Okay, in terms of occlusion, as I mentioned before, these children often have mild amblyopia, so you will treat them accordingly. You first need to prescribe the glasses, and with the glasses, because it's making them bifoveal, that in and of itself can improve visual acuity. Also, when you start occluding the patient, once you've achieved equal vision, these children hold their visual acuity and aren't at risk of losing their vision again or becoming amblyopic again because when they're wearing their glasses full time, they're bifoveal. So it's a matter of diagnosing these patients early, prescribing the glasses, and then any amblyopia treatment from there. Okay, now is there a role for orthoptics in the management of patients with a fully accommodative esotropia? Yes, there is. You can actually assist a patient to get out of glasses. And what I mean by get out of glasses is teach them to control the ESO deviation without the hypermetropic correction. However, it's important to note that not all children are suitable for orthoptics. And over here, you'll see I've mentioned that the child must have no more than 4 diopters of hypermetropia and no more than 1 diopter of SIL or astigmatism in order to be suitable for orthoptic management. When they have more than 4 diopters of hypermetropia or 1 diopter astigmatism, it's very difficult for the individual to control the deviation without glasses. The other consideration is the age of the patient. You can't train a child out of glasses at the early stages because they're too young. So you're looking at doing these exercises when the individual is older. Usually as they approach the 10 years of age, 8, 9, they start to become able to perform these exercises. You will judge that depending on the child and their maturity, but you're not going to be able to perform these exercises in a young 2 or 3 year old. Now, when we give these orthoptics exercises, they actually can be done in stages. There are 3 stages. Let's go through each of these. The first stage is if your patient is suppressing when manifest, then you must anti-suppress them. You can't move forward to stage 2 or 3 unless they have the recognition of diplopia. Now, if the patient does experience diplopia without their glasses, then you can skip stage 1. And many children do. They appreciate diplopia with the glasses on and you don't need to worry about prescribing any anti-suppression exercises. So moving on to stage 2, what we want to do here is start assisting the child controlling the deviation by firstly recognising when the deviation is manifest and when it is controlled, and then also improving the fusion range or fusional divergence. Misty Clear is the exercise that allows the individual to recognise when they're straight and when they're not straight. Essentially what this means is that with the glasses off, when an image is clear, they are accommodating and therefore have an esotropia. And when the image is blurry, so misty, they're not accommodating and therefore they're straight. So they learn to understand that the difference between a clear image and a blurry image is also the difference between when they're manifest, when they have a manifest deviation, and when their eyes are straight. Okay, we also during this phase want to improve the fusion range. So we'll probably need to do this with glasses on because without the glasses there's limited control at this point. And we'll improve that negative fusion range, so fusion with divergence. The other thing we want patients to recognise is physiological diplopia. So we want physiological diplopia to become the guide of when the patient is straight and when the patient is manifest. So the presence of phys dip means a patient is straight, and the absence of phys dip means the patient has a manifest deviation. And you can do this with the glasses on and without the glasses. So with the glasses on, they should appreciate phys dip. Without the glasses on, it will vary depending on whether they're manifest or not. Now, the reason you need physiological diplopia to be recognised is also because stage 3 relies on phys dip. So when you're going to move to stereograms, we need to be able to have the patient appreciate physiological diplopia. So stage 3 now, what we're trying to do is improve control of the deviation by dissociating accommodation from vergence. So this means what we're trying to do is disconnect accommodation from vergence and exercise relative fusional vergences. And for an esotropia, we want to exercise negative relative fusional vergences, so we can give the patient stereograms and it'll be in stare through. Again, remember that the patient will need to clear the images, the cats in this example, so that they are actually exercising relative fusional vergences. This you'll do with the glasses on in the first instance. You can also give the patient bar reading, which is actually very useful for these patients. The other thing we can do is give the patient minus lenses with the bar reading, and this will improve negative relative fusional vergences. And what you're doing here is, with the minus lenses, you're forcing more accommodation, which leads to the patient needing to do more accommodation or accommodation ahead of vergence when they're trying to read. Now, it might be very difficult to give concave lenses to patients who already have glasses, so this may or may not be an option. If you're treating them in the clinic, you can do this in the clinic. As the patient's binocular functions improve, what we can do is start lifting the glasses and asking the patient to control the deviation without the glasses on. And often it's best to do this in a supervised environment in the clinic to teach them in the first instance how to go about trying to control the deviation without the glasses. And what we'll do is we'll also slowly reduce the plus. So say they're a +3 hypermetrope, you've gone through stage 1 and 2 and part of stage 3, you're improving these relative fusional vergences, you feel it's time to start letting them take the control of the deviation without the glasses, then what you do is, rather than discard the glasses immediately, is reduce the plus. So you go to 250 as an example, or 2 diopters, depending on what you feel in the clinic the patient can cope with. So you'll be progressively reducing the plus lens until the patient can control the deviation without the glasses at all. And lastly, let's talk about the more invasive procedures. With surgery, it is contraindicated in patients with a fully accommodative esotropia. You should not recommend surgery for the esotropia in these patients. Why? Because the deviation is entirely related to accommodation. If we go back to these images, we can see here that this is, let's say, a 30 diopter esotropia. And with the glasses on, the patient is completely straight. So the question is, what do you operate on? The patient is straight here, but there's a 30 diopter esotropia without the glasses. If you operate on the 30 diopter ET, when the patient puts their glasses on, because there is a strong relationship that this patient has between accommodation and their deviation, what will happen is that the glasses will relax the accommodation and the patient will become exotropic. So post-operatively, the patient will be straight without the glasses, put on the glasses, and the eye will now be exotropic. So you're at a very, very high risk of causing a consecutive exotropia if you operate on a patient with a fully accommodative esotropia. Now, when I say you only operate on a non-accommodative component of the strabismus, it means that you only operate on whatever deviation remains with the full correction of the patient. So here we see there is no deviation or no manifest deviation with the glasses on. So there is no non-accommodative component of the deviation. The entire 30 diopter esotropia is corrected with the hypermetropia. So the entire deviation is accommodative in nature. Okay, and lastly, we have here the option of laser refractive surgery. Because this is related to refractive error, laser refractive surgery is an option for these patients. However, it's generally not recommended in children. It's preferred that they do this as adults. So in the interim, if they don't want to wear glasses, to wear contact lenses. And as they're older, consider refractive surgery. Okay, that brings us to the conclusion of this video. Thank you for watching.